I believe we have quite a few apologies, Nathan.
Yes, Susan Parsonage, Matt Pope, Graham Evers, George Drummond and Co, and Charles Gates.
Thank you.
And Sarah Hobstone Catchings.
Any other?
Yes, there are some apologies on her behalf.
Okay, thank you. Minutes of the previous meeting. Has anyone got any comments on these minutes?
Absolutely brilliant summary of everything we said. I approve.
Okay, if Stephen approves, then we will have to, don't we? Thank you very much. Any declarations of interest? Don't believe we've got any public questions or any members' questions. Is Lewis here yet?
Lewis is online, yes.
Lewis, we're going to take your item Q3 Better Care Fund submission first. Well, first because Stephen has to go, and though we will probably get to it anyway, it's worth. That's the one that we want to approve. So, could you go through that, please?
Of course.
Probably won't take too long. He's fairly good at succinct.
Thank you. Can everyone see what I can see?
Yes.
Outstanding.
We don't really know what we can see, what there is, but assuming you can see what's on the screen.
There you are. Okay, so quick roundup of our Better Care Fund submission. So the national conditions which we had to meet, we have a jointly agreed plan. We have implemented BCF policy objective 1 around enabling people to stay safe and independent at home. We've implemented BCF policy objective 2 around providing the right care at the right time, the right place. And we have maintained the NHS contribution to adult social care and investment in NHS commissioned out of hospital services. And I think I see Helen in the room. Thanks to no small part to Helen working her socks off, we have an agreed section 75. So thank you, Helen. With regards to our metrics for Q3, we're on track for all of them at time of reporting. We haven't met all of our metrics for all of the quarters so far, but this for Q3, we are looking good. And with regards to our funding, this is an overview. Essentially, if you look at this, we are very as near as darn it to 3/4 of the way through our funding against the projection that we had at the beginning of the year for the spend that we have. So in Q3, we've spent roughly 3/4 of the money, so we are in good shape. And that's it.
So did we miss the target in Q2?
Yes. This is from memory. I believe we missed the admission avoidance target in Q2. We didn't hit that one, but other than that, we did. And we, like I say, this year we're doing very well with regards to our performance against our Better Care Fund targets.
So what does that mean that we missed one target? Can we make it up again? Or?
So if you look, so yeah, with regard to that, we would have missed that portion of the risk share should it be made available. But overall, for our admission avoidance work, if you look at where we were this year compared to where we were last year, there are fewer people going in. And if you total up the 3 targets to point, it is less than the overall thing. So we had a really bad Q2, but we did well in Q1 and Q3. So those together, it's less than the, if we total it up, if you see what I mean.
Yeah. So
cumulatively, that's the way I'm looking for.
Especially if we did have a bad quarter.
Sorry, yeah, we just had a bad quarter, yeah.
Yeah. So, but that's good that we're doing well, really. So that,
yeah.
That's positive. Any questions about that?
No, just to say it looks very good, very encouraging.
Absolutely.
Okay.
It's because we've got such good partners.
Indeed, absolutely right, Lewis.
So we have to have a vote on that.
There isn't a recommendation.
No. Just accept the submission. The submission, yeah.
Yep.
Okay. All those in favour? Okay, thank you very much. Thank you very much for that, and Stephen and I can now breathe a little bit better.
If we carry on at this rate, we'll get through the whole agenda.
Yeah, so that would be something. Okay.
I'll take my leave. Thanks very much. Bye.
Thank you. Okay, the Wokingham pharmacy update. David, yes, sorry, David. Nice to see you this afternoon.
Yeah, it was a very good session this morning, so thank you for the invite.
Okay.
So in terms of the update, I think you've had the papers, haven't you, submitted to the board? I'm here really to answer any questions you may have about current provision of pharmacy. I would like to add before I answer any questions that following the launch of Pharmacy First, which is where patients can refer themselves for 7 minor conditions, and GPs can now refer patients for those same conditions, where a patient may receive treatment if appropriate. So they may get antibiotics for certain conditions like UTI, sore throat, whatever, has been initially, what we can see with the data we've had, a fantastic success. And will go some way towards alleviating some of the pressure with our GP practices in Wokingham specifically.
Excellent.
Just, David.
Yes.
A question, if I may, David, on that point. It's clearly been helpful in terms of reducing the pressure on doctors' surgeries, which is good news. But is it increasing the pressure on really rather hard-worked pharmacists? Are we just transferring
I don't disagree with you. Some of the work that is now being funded by the government was being done almost free of charge in terms of time spent with patients. And if you factor in the bouncing around of patients within the healthcare system because they weren't going to the right place first time, it's reduced that somewhat. And it's given pharmacies a little bit of a lifeline when it comes to funding, because with the indicators we have so far, they can actually invest in their pharmacies, in workforce and software and processes to make sure they have got extra time to spend with patients face to face. So yes, there is extra workload, but because it's funded appropriately, which is what obviously community pharmacy needs, it'll go some way towards helping keep the existing pharmacies financially viable for the short-term future.
Thanks very much. That's very helpful.
And as we were saying this afternoon, pharmacies are in a bad state financially.
It's a challenge, absolutely, with all the different things, cost of living, national minimum wage, reimbursement of medication not appropriate from the government, loads and loads of different things, all like a perfect storm, really. This does help.
Andrew and then Debbie.
Yeah, David, that sounds really positive. Have you had any feedback from patients and users as well?
Yes, we've had feedback has been mainly positive, where they're delighted to be able to walk into a pharmacy at 8:30 in the morning and get treatment sort of 15-20 minutes later. We've had patient expectations, perhaps, so slightly more negative, doesn't match with what pharmacy is offering. So they've misinterpreted perhaps some of the TV advertising or media. And I think the Bob's comms team has done a brilliant job with social media and adding to the national campaign to try and educate patients. And I'm sure Alice will come in here, but we are looking to get formalised patient feedback later in the year, August, September, to number one, find out how many patients are aware of the service, and number two, how's it going, basically, is it working?
Yeah. Debbie?
Yeah, I was just going to give on the ground feedback, really.
Good.
So we met with one of our pharmacists, I think day 3 of it working. So just saying, how is it working? And they were really quite excited about it because, as you say, it was bringing funding in for what they were probably already doing to a certain extent, but not being paid for. And we've kind of opened up our doors and just said, look, if you want to come in and learn from our minor illness team, because in the same way as, you know, our paramedics are great if you've been, you know, had a heart attack or hit by a bus or anything, but looking at someone's ear, which seems fairly simple, takes a bit of training. So we've kind of opened that kind of facility up to them. So the one thing I was going to ask is there any formal feedback when perhaps a diagnosis has not been what we would have done?
Yes.
And I'm not actively looking for that. I think we're just doing on case by case and just learning together.
Yes,
but is there
absolutely.
a formal avenue?
Yes, it's very new to everybody, isn't it, Debbie? And
Yeah,
I appreciate your help with training, and with Julie's help, we've actually funded a formal ENT training that includes practical examination of ears for over 350 pharmacists across Bob, which is brilliant. In terms of the process, if a practice digitally refers a patient to a pharmacy, you will get feedback, whether it's a great outcome, where they get medication, that'll come back into your DocMan as a PDF at the moment, but in 2 weeks' time, it will get ingested straight into patient record. If there is an inappropriate referral, then you should get feedback again from the pharmacy on the reasons why, if they don't fulfill the very tight criteria that pharmacies are working to. And we're looking at the data with Julie and looking for patterns. There's some patients never turn up for whatever reason to the pharmacy. We can't get hold of them. But on the whole, it's positive. There's obviously going to be a percentage of patients where they do have to go get referred somewhere else because the signs are worse than previously thought, or they need further advice on a particular condition because it's clinically safer to do it that way.
So I understand that part. I was thinking that when a patient has been seen by a pharmacist and then told they need to come and see us, and the diagnosis they've been given by the pharmacist is not what we give.
Okay.
How do we feed back? I say we're just speaking to pharmacists direct if there's
That's
big
maybe
concern.
something for Julie to answer, because that would be through the quality assurance part of the ICS, wouldn't it, Julie, in terms of clinical governance and whatever.
Yes, thank you. Hello, everybody. I am Julie Dandridge. I am the head of pharmacy, optometry and dentistry as one of my titles for the ICB, and David and I have been working very closely on Pharmacy First and on community pharmacy. Debbie, I love your approach with your local pharmacies. I wish we had more like that, but yes, we are working out how we introduce that sort of escalation route, because this is about learning together as we go along, isn't it? And I expect we'll have an escalation route into the ICB. We would expect obviously conversations initially with the pharmacist, and the practice, but we would be keen to capture, and I'm sure the pharmacies would be keen to capture any issues and numbers like that. So something will undoubtedly be coming out soon.
Thank you.
One other thing, David, with that, I think sometimes it's taken time for some of the pharmacies to get confident that they're giving the right, and certainly I know my wife's a GP, and she's been a bit frustrated sometimes when people have come back to her when she thinks the pharmacy could have dealt with it. But sometimes they need to know, that they're going on the right way to get that confidence to do that. I think and it is a new step. So.
Yes, absolutely. And we found that if a practice uses, I'm sure that Debbie does, the referral triage button on EMIS, that does lead you through the correct pathways and should filter out any referrals that would go in the wrong direction. But you're right, there's a level of competence and confidence with the pharmacists, and we found they come into their training with a shiny new otoscope to do some ear examinations and quite nervous, like they were when they first started doing vaccines a few years ago. But after the correct training, a bit of practice, obviously a few sort of case studies, the confidence just starts to grow enormously. And I've had phone calls over the last few weeks about how fantastic they feel now that they're helping patients, face to face, and not stuck out in a back room somewhere just putting labels on boxes, which is is the way that pharmacy needs to go if it's going to fulfill a role within primary care.
it's also, can I just come in on the back of that? Apologies. It's also worth noting that actually what the pharmacists could do is quite restrictive. So they can only give an antibiotic if they meet certain criteria. So if any of those criteria are not met, they might have to refer back to the GP. You know, if the age is slightly wrong, or if the temperature's not quite right. So I think, and I think that's what I think the service almost needs to embed, given the criteria that we've got at the moment. But I think there will be a bit of movement of individuals in the public, but that's probably in terms of clinical safety and clinical assurance and all the things that Debbie mentioned about misdiagnosis is there to sort of safety net patients at this stage of the rollout.
Yes.
Debbie, you've got your hand up again.
Yeah, so just two things. I was just going to say the same as Julie. It's, you know, it is really quite defined and very, very safe. I suppose the other thing I'm hoping that will come out with this is what David just picked up on as well, is, you know, pharmacists have always been part of our communities. They were always able to give advice, not obviously, you know, sometimes knowing what needed to be given, but unable to prescribe. And there are a lot of pharmacists who, as David has said, have got a little bit bored of putting, you know, tablets in a box. So I'm hoping that, you know, if they've got skills of working face to face with patients, yes, that we will enable more and keep more pharmacists within pharmacy.
Yeah. Can I just respond to that? We are actually, this is the first part of potentially pharmacists becoming independent prescribers. And there's a massive campaign at the moment working with the NHS to really upskill our pharmacists. And hopefully over the coming years, it will change from a PGD. So a very strict criteria to give pharmacists more freedom to be able to prescribe alongside all prescribing colleagues within their system, the ability to be able to treat patients without having to bounce them around the system.
Alice.
Can you hear me?
Yes.
Yeah. Okay. David, in the materials that you have given, you've shown us posters, right? There are posters in there. And Julie was mentioning age range. Is there restrictions in the age of who they see?
But for the condition, so for example, for earache, Pharmacy First, they can only give treatment to those between the ages of 1 and 17. It doesn't include adults.
Okay.
So there is strict criteria.
Okay. Because
I can send you a poster to demonstrate that if you like, Alice.
Yeah, I think that would be good, because I don't think the poster is that clear, and I think people will think everybody can go.
I don't think you're wrong there. The post has become too messy and detailed if they start putting too many restrictions on them. So some of the messaging is diluted. And I've shared some resources with some of our practices around, you know, who not to refer, who to refer, and some guidance around some of the clinical pathways. But you can't put everything on there because it's very, very detailed. But I'll send you some stuff separately, Alice, to
thank
give you
you,
some
because
guidance.
I think that makes a big difference, because you know, we are saying to everybody, you know, we're saying go to the pharmacies first, and then they go and have restriction. It's not going to be good. So it's again, I always talk about the messaging. So you know, if we want this to be successful, we need to make sure that the messaging is correct. So I'm happy to help you all there, because I was looking at it, I'm thinking, and then when Julie said about age, and then that's when I went, there's nothing here to say about the age. I'm still awake.
Very impressed.
So yeah, please do send us the stuff, and then we can share it as well.
Yeah.
Thank you.
Okay, I think that's everyone. Thank you very much, David. And
Thank you. It's been a pleasure.
Very positive to have you in.
And I'm here, you know, not just on these calls, but any other time, you know, Debbie and your colleagues and Alice, obviously, and anyone else that wants to drop me a line or give me a call. I'm open to conversations, you know, all week.
Very much, David.
Okay. Thank you very much.
Thank you.
Okay. Thanks very much. Right. We go on to the community pharmacy and dentistry provision from Bob.
It's Julie. Yeah.
Sorry.
Thanks. Thank you. Yeah, thank you. And David has done quite a lot of the bit, so so I don't really want to go into it probably too much more. I know there has been lots of concerns around pharmacy closures over the last year or so. Oh, David's come back. Thank you, David. We are hopefully getting to the end of those notifications, and we are certainly now starting to see more prospective people applying to open new pharmacies and putting that through the process, which I'm sure you will be and are currently being consulted on. So I think we've seen a turn in the community pharmacy provision, recovering from COVID, and then the sort of the Lloyd's stepping out of the market. I also think we're now seeing more independent pharmacies who really want to be part of that high street, that local community, as Debbie Debbie described earlier. So that can only be a good thing. As you've mentioned, workforce is an issue in pharmacy, and I think that there's some more work that we need to do. You know, we're really lucky having a school of pharmacy on our patch, very close to where you are, and so that will be important to do a little bit more with them, which I think as Bob we can probably do better with those local relationships than previously was done with NHS England. And then finally, of course, we've got, I know you've discussed the Bob primary care strategy, and I think that really presents a unique opportunity for both community pharmacy, but also our dentistry and optom colleagues, as it sort of brings them in line with general practice. And David's been heavily inputting into that going forward. I think there are some digital improvements that we can make with community pharmacy, making them, able to communicate digitally much easier with general practice and with the other professions. And finally, just to say, the NHS app, and I know people associate that with GP practice, but actually that has made a difference to community pharmacy as well. You can now track where your prescription is. You now get a barcode that you can take, so you don't need bits into the pharmacy. So there is quite a lot of benefit of the NHS app, and I know that's something that we in Bob ICB are really actively encouraging people to use, as it will be able to have more and more functionality. So, Chair, I think the exciting bit is the pharmacy first, which David's covered, but happy to take any questions on that.
Dentistry also coming into this.
Yep. Yeah. So shall I go on to dentistry?
I think it's good to go on to dentistry, and then we can have questions about that.
Yeah.
Dentistry is a big subject.
Absolutely, and I'm presenting the paper on behalf of my of my colleague Hugh O'Keefe, who works in my team. We all know the issues that facing with access to services and dentistry, and the fall in provision since COVID. I think the paper presents some of the challenges that have been faced with contract handbacks and under provision. But I did want to focus a little bit more on what actions we're taking to try and address those challenges. I'm sure you'll be aware of the flexible commissioning dental scheme, which we've had available across Bob, one of the first ICBs to introduce that, which allowed dentistry or some dental contracts a bit more flexibility and be able to help and support those individuals who are more vulnerable, especially those who hadn't received any treatment or any care in the last 2 years, but new to area people, but also our asylum seekers and sort of looked looked after children, and we've just done an evaluation of that service across the patch, which showed that we had 32 practices from across providing that service. They saw 6,000 extra patients, just over 6,000 extra patients, just under 9,000 extra attendances, and actually with good positive feedback from both dentists and the patients and the public, and we have just agreed to roll forward that scheme into the next financial year, into 24-25. So hopefully that will help our most vulnerable patients, our population. The other thing that we've done is recently we have gone out to look to replace some of the lost activity from contract handbacks, and you'll all be aware of dentists that have said they no longer want to provide NHS services, and we have managed to secure across Bob an extra 70,000 units of dental activity, including 14,000 or just over 14,000 in the Wokingham area. So this is existing dentists just being able to increase their activity and provide more services. You will be aware of the NHS dental contract reforms that have been that were announced, which has some benefit to our population. There is a premium now for new patients to be seen, so this will help access, at least for the first start, but also there's some work, we don't know much detail at the moment, but in terms of the oral health improvement and prevention and going into schools and early years settings to help children learn how to brush and look after their teeth right from the early stage, the Smile for Life program, so I think that will really help. So at the moment, those are the two areas of the dental reforms where we are really concentrating our effort, because we think that will really help the population, and we know how important teeth are. Very happy to take any questions on the paper or any more detail.
I've got Prue and then Alice.
So I'm sorry this comes across as a bit challenging. So on page 9 of the agenda, there's the table of I think they're called units of dental activity that are commissioned per head of the population. I see that Wokingham is quite down near the bottom scale, so 1.07, which is quite low. It's not the lowest, but it's quite low. And then above the table, it says these levels are based on levels of activity commissioned at the point the current dental contract took effect in 2006, and any additional activity commissioned by the PCT or NHS England since then. Quite a lot has changed since 2006, and I'm wondering, do you do anything to actually assess the need for NHS dentists in the area and adjust your things to that, as opposed to deciding what we used to get and giving us more of the same? Because this is something that I notice. I do children's services in school funding. Our level of school funding is based on what happened when we had a county council and how it ended up then, out with minor. So all the stuff is baked in and takes no account of our actual circumstances. So I'm wondering what you do to assess whether the amount you're commissioning is actually the amount we require.
Thank you for that question, and it's a really good one to help us with this. So I think this information that we've presented here is how we are assessed by NHS England, but is based on recovering levels of activity to pre-pandemic levels, because as you can see from the graph, we are quite low in that respect. But actually what our public health colleagues done is have assessed and have done a health needs assessment on dental needs. Now I couldn't off the top of my head tell you when the last one was done for Wokingham, but I will go back and check that, because that should help define our direction of travel and where we need to commission more services so I think our focus has been on maintaining levels, but I do take on board that actually that might not be acceptable in the first place. I mean, I've worked in primary care for many years, and access to dentists has always been an issue. So I do take on board that point. Thank you.
Thank you.
Alice?
Thank you, Jack. Julie, just to share with you that every time an issue turns up, I do have a conversation with Hugh a lot. It's the list that you have got about the flexible commissioning. Okay. It's not very, very clear to the stage whereby we are having to I am having to constantly ask him, can this client have this? Can this client have that? You know, so if you're going to take this forward, I think some clarity, a bit more, you know, in a little bit more detail might help. Also, the other thing is also what I've had to do is, even though we were informed that certain dentists will take the vulnerable groups, when the vulnerable person went to the dentist, they turned around and said, oh, no, we don't do the service. So I've had to go back to Hugh and say, no, and so, you know, it's like a ping pong ball kind of thing. So I just think that we would just have to try and make it a little bit better, because most, you know, we've got to get it right, because it also has an impact on us as Health Watch, because we are giving them this information. And we came to the stage whereby we turned around and told the client to go and say to the dental surgery, Health Watch told me to renew, kind of thing, to, you know, so that so they knew that the information came from us. So I just think that's an element of needing to tighten this a little bit if you're going to take it forward.
Yeah, and I think
I
think we certainly have tightened the criteria in terms of how the practice publishes the fact that they're doing this. But Alice, really take on board our need to probably describe it better and potentially do a leaflet that you could share with the people that are approaching you, etc. So we'll take that aboard. And in fact, that's one of the real themes that have come out of our primary care strategy engagement, is actually we need to communicate better about what services are being offered and by whom. So it's part of that general theme, but yes, when Hugh's back from leave, I will certainly pick that up with him.
Yeah, and he's got a report waiting for him to have a response as well, just to say that we've just sent him the learning disability and dentist report.
Okay, thank you. Hugh's off for 2 weeks, so he's using up his leave, so I'm sure he will respond to you when he's returned.
Thank you.
I think that's all the questions, Julie. Thank you very much for what you've done, Simon. And we'll keep an eye on both the pharmacy and the dentist, because I think both of them are important. And it's getting things like that right, which is so important in primary care, isn't it?
Yeah, absolutely. Thank you very much for having myself and David. Yeah. Cheers. Yeah. Thank you all. Bye bye.
Thank you. Goodbye.
Okay. Mark, I believe it's you for Wellbeing.
Can I ask a question, Joe? We've got an item 54 that says it's on page 35 and 36, and it isn't in the papers. I meant to raise this before. It's
where it is. I don't know.
My page 35 and 36 on the agenda item 56. Oh, it's not on pages 35 and 36.
53.
Right. Okay. So there's a mistake in the agenda. Right. Okay. That explains why I couldn't understand why that was part of the report. But okay.
Hello, everyone. I assume you read the report, so to keep it concise, I won't go through it. The Community Wellbeing Outreach Service, aka Health Checks for CHD, is going really well. We are just giving an update of what it's about. So basically, it's a project to do health checks in the community to help tackle the inequalities, health inequalities, focusing on coronary heart disease. So the focus on how we can reach people at risk of coronary heart disease that have disadvantages due to their backgrounds accessing healthcare. So whether that's ethnic minorities, people in socioeconomic disadvantaged areas, etc. Very much a whole systems approach. It's a really exciting project. We are engaging with primary care. We got a primary care lead in Lizzie Mottran working with us. Public health, Karen is working with us on this, plus the integration team, Lewis, myself, and Emma Halcox. And I'm very pleased to announce today, hot off the press, we've just now appointed a voluntary sector partner. So Involve are going to come on board, and they're going to bring so much to the party as well. So it's a whole systems approach to this. And also it fits into our wider strategy of prevention and how we support residents by being present where they present. So that's what we intend to do. We're going to try and take these health checks out into the community and give access to people where they access their local services, whether it's food banks, whether it's faith groups, etc., or community groups, carers groups, things like that. So to offer them a health checks for people who don't necessarily want to come to a clinical setting or don't respond to health checks normally. So building, I see Andrew's here, building on the work that we've learned from Meet Pete, for instance, and we've had Meet Pete from Royal Berks in Norries all this year, and we've got the last one tomorrow actually, so we'll be taking over from that. And the other real advantage of this is because it's health checks. So the primary thing is we're providing an accredited NHS health check, which is great in terms of the quality standard, but we're also bringing in that social prescription element. So we'll have a dedicated social prescriber employed by Involve, who work with a lot of our PCN practices already, to dig down deeper if necessary to look at sort of the root causes behind people's issues. So, you know, you're not accessing exercise because actually your priorities is you're worried about your washing machine not working, you know, your financial issues, your well-being, your mental health, all those other wider terms of health that we know that are getting in the way or actually drive some of the drivers behind the risk factors. So that's what we're doing. In terms of where we are looking to mobilise really at the beginning of April. We have staff in post. They're starting on the 18th. We have a really capable manager that's very quickly mobilising all the bits and pieces. We've got training induction happening with Reading University, another future partner in terms of doing placements for pharmaceutical students, for instance, very topical for today. And we're reaching out to a lot of our community already. So, for instance, we're working with Share, who've got 5 sites already across the borough in all our deprived neighbourhoods, and we're going to be working with our PCN colleagues to make sure that we have representation or presence in each one of the PCNs as well. So that's where we are. It's really come to head now. It's been a long journey to get there, but we're about to launch. So hopefully I'll come back next time and say how many we've done. That's it.
Okay, thank you very much, Mark. If anyone knows, Alice has a question.
You're muted, Alice.
Yeah, can you hear me?
Yeah.
I mean, how long is this project for 18 months? Is that what it is?
Yeah.
Okay, so I'm just trying to understand, when would you say that this project has made an impact to the client?
Well, the 18 months will start when the staff starts, because they've got 18 months contracts. So the 18 months from the 18th of March is the thing. We're also lucky that our public health colleagues will be doing the evaluation for us in Wokingham. But also, I know, Alice, I think you might be leading an evaluation in Reading as well. So I believe Health Watch.
Yeah,
they were.
We are leading the one in Reading. Yes, we are.
All right. Sorry. Hope you weren't surprised about that.
No.
So part of this, obviously, will be the first question we'll ask when people come in is do you mind being contacted later on? You know, for any service, and we'll be asking about their experience of having a health check like this, but also opportunity for them to follow up maybe a few months later about have they taken on board some of those changes that they might want to engage in, like dietary change or lifestyle changes. But also the public health team will be looking at how effective it is. So we want to get out of this some learning. So is this the way we're going to do health checks in the future? And also to look at other projects within the borough about how we actually reach to these harder to reach population cohorts.
I mean, my worry is a lot of time and money has been spent on this project, but I just want to see what is the benefit for the community and how would they know the benefit. That's the thing. That's how would you know the difference? Is it the lifestyle change or what? I don't know. I can't see the end of this because it's so short. I mean, my problem with this project is nothing is sustainable. And that's
Ingrid, you want to come in?
Yeah, thanks. I think the challenge is valid, Alice, and I think that we as a system have to think about how we understand the short-term markers of evaluation as well as the long-term. Clearly, we're not going to see in 18 months a reduction in cardiovascular disease in Wokingham. That's too much of a long-term measure. But we will be able to see who has, for example, was not registered with a GP, who is now registered with a GP, who has not got a record of a blood pressure in the last 5 years in their GP records, who now does have a measure of blood pressure. Those things are important, and they are markers along the road to that ultimate outcome of cardiovascular disease. So I think there are, as well as how much did someone respond to the behaviour advice they got, and did it have an impact in their daily life, when we address the more holistic picture rather than just giving a kind of one-stop advice like we would with the normal NHS health check. So I think there are elements that we can learn from. I think that there is a flaw in the whole programme, which is that it's funded for 18 months and then that funding goes. But I think that it's partly upon us to demonstrate the value in this model of delivery to see if we can, if it is successful, convince organisations within the system that the funding needs to continue. And I think that I know the ICB are with us on that. So that's the ambition.
It's just that once you get the cohorts in and then all of a sudden it stops, these are the cohorts that tend to have a lot of stuff put in and then it stops. And that is where my worry is about. You gain this trust and then it's gone again. Then you're having to, it's just like a yo-yo. And that's what I'm trying to say. How do we stop this is what they ask us, Thank you.
As Ingrid said, I think we've got to prove that it works and make sure that it keeps going, because that's the bottom line if it's working. So, Nick.
Thanks, David. Thanks, Mark. I've seen your presentation before, obviously, but on one of the slides in a previous presentation, you showed an element of healthy lifestyle advisor input. So I'll raise my point again and extend that, but for this board rather than the meeting we had last time. I really think there'll be practical benefit by having some practical support. So standing alongside somebody in their kitchen, for example, with a dietitian, showing them how to cook food properly, particularly if they've got fresh food from share. I think we're awash with signposters, people who are doing signposting in all sorts of different roles. And that's okay if people can actually, follow that through and have the resource to and capacity and capability to pursue that themselves. But actually standing alongside them and doing something practical that they can take away and that stays with them would be a huge benefit, rather than just spending money on people kind of organising things. I don't mean that to sound disparaging, but I think there's a lot more practical benefit we get. And the further extension of it really is, where is the link into physical activity and sport? There's a huge amount of peer-reviewed evidence that shows the benefits of being active, physically active. And particularly when he's focusing on cardiovascular disease, it's enormous. And yet, I've worked in the sector for 40 years and I'm still asking the question why the health system and the health service hasn't really picked up proper links to physical activity. There were GP referral schemes around in the 80s and they still talk about them as being, that could be quite beneficial. On the other hand, people say exercise is the best medicine. If we could put it in a tablet, it would be, a fantastic win for everybody. So I'd really like to see where that link can be made.
I think we need to see this as one piece of the jigsaw. It's not the panacea for all ills. In terms of our intention is not just to do a health check and run. That's why we want the social prescribers there, and that's why we want to build it into all the other initiatives doing. So, for instance, we're working at Gurdwara at the moment about doing monthly meetings down there. We're talking about other things like carers and dementia, etc. So we want to bring different voluntary groups in. Since Advice, for instance, they could bring their van up, First Aid can as well, and link into other projects. And we will find out actually if that's something they need, that sort of cooking advice or whatever as well. So that's one of the things we're going to have the evaluation. I mean, in terms of exercise, yeah, I can't agree more. You know, if someone invented it as a pill, they'd be very, very rich, wouldn't they? So, but one of the things we're also linking up with Get Berkshire Active. So they are going to lead in our training for our staff, but also other staff around about how to influence and have those conversations about how to get people to change their attitude to movement, basically. So that's another partnership we're developing as well. So you know, I know, Nick, you've got a long pedigree in this thing. So hopefully you could also be involved as well for your organisation as well.
Thank you very much, Mark. I'm afraid we've become incorrect with Stephen had to go to another meeting, so I've got to terminate the meeting now. I'm sorry about that. I know that some of us wanted to hear about Marmot and things, but hopefully we can hear about that in the future. But thank you all very much for coming, and we'll see you again.
Thank you.
Thank you.